Hello, everyone, and welcome to this special webinar session on guideline development and use in low-medium income countries. This is a topic of great importance, and we are looking at having exciting discussion about it. Before I move on, I will like to share these housekeeping rules. First, if you are not actually talking, please make sure your mic is muted. You have the freedom to keep your video on or off during the presentation, but as if you put it on, try to minimize any form of distraction that can distract others who are on the call. Thirdly, we shall be having uh, a discussion session, a networking session after this particular program, which will be off recording, and you are free to join. We also share more about Gene Africa. We share about opportunities to collaborate and to present as well during that particular networking session. At the moment, we are still waiting for our first presenter, who should be here in a minute. So at the moment, this is how the program will run. First, we have a 25-minute presentation by Professor Suresh, who will be talking about stroke guidelines in low-medium income countries. After that, we'll have some panel discussion where the experts will share their knowledge about guideline development. We'll share practical experience that can actually help move this forward from their perspective from their respective fields. After that, we'll then have questions and answers, which will cover all the topics. And you are also free to share with us in the chat. Introduce yourself. You can share any contact or link to your profile, just so that we can look at what you're doing and we can effectively collaborate. So at the moment, I will give the floor. First thing first, I am Etienne Gay, a physiotherapy and a cardiac rehabilitation specialist, currently the chair for Gene Africa. And I would like to introduce our able secretary, Nuela, who will then introduce our first speaker on the program today, Professor Sureshkumar. So, Nuela, please.
Thank you, Etienne. Welcome, everyone. You are highly welcome to our March webinar with the theme Guidelines Development and Use in LMICs, Perspectives from Interest Holders. We have our esteemed presenters. Firstly, we have Professor Sureshkumar. He has a very interesting profile. He's an experienced academic researcher specializing in disability and public health for over 2 decades. His work focuses on improving access to rehabilitation services, integrating rehabilitation into health systems, and advancing disability inclusive health policies, particularly in the Global South. Also, he is an associate professor at the Northumbria University in the UK and an honorary associate professor at the London School of Hygiene and Tropical Medicine. Professor Suresh also serves as a trustee of the Royal College of Occupational Therapy in the UK, and he is the delegate for the World Federation of Occupational Therapy and associate editor of the British Journal of Occupational Therapy. He equally leads several global initiatives, including serving as director of the Cochrane India Network affiliate for public health and disability. He is also involved in ISRRA, GCSRA, and WHO World Rehabilitation Alliance. Professor Suresh has published extensively with an H index of 18, placing him among the top 10% of global rehabilitation researchers. You are highly welcome, Professor, to this edition of our webinar, and would like you to share your perspectives on guideline development for LMICs.
Thank you so much. I should say GI in Africa for this particular opportunity. Is it possible to share my screen?
Yes, please. Thank you. Go ahead and share your screen and then
Thank you.
do your presentation.
Is it possible to see my screen now?
It's coming on.
Go.
Double click. Good.
Yeah.
Yes, we can see your screen. At least I
Perfect.
can see. Yeah,
So I have about 20-25 minutes, right?
that's right.
Yeah, I'll keep it short. Um, good afternoon, good evening, and greetings, everyone, and thanks again to the GI in Africa, especially TIN, for this opportunity. I particularly represent Global Consortium for Stroke Rehabilitation, the Cochrane affiliate for disability, and public health Cochrane India Network, and my university for this specific opportunity. I just wanted to give a brief outline of my experience working on looking at developing clinical practice guidelines for stroke care in LMICs. We've started to do that at GCSR. And I wanted to share what's missing in those specific components, especially from the perspective of disability and rehabilitation. I'm not going to talk about this a lot to this esteemed community in terms of what happens to stroke. We all know that stroke is the leading cause of death as well as disability for the past few decades. And although the rank has remained the same, the numbers have actually gone higher and higher, particularly in low and middle income countries. In terms of prevalence, this might actually have a little more blue areas, which actually depicts a little lesser prevalence in terms of stroke. But in terms of the disability adjusted life years, if you see, there are more orange, yellow, and um, pale yellow shades, which actually depicts the issue is actually immensely affecting low and middle income countries, particularly in terms of stroke related disabilities. The key question that we had before we started to look at that development of clinical practice guidelines is how to actually address the issue of disability in low and middle income countries that's coming through stroke. And what we primarily looked at was, number one, is there a guideline in place, or is there a common guideline in place that low and middle income countries can adopt, and then ensure that disability is also kind of managed really well to ensure that the numbers are coming down. And number two, in terms of the guidelines, what is the quality of the guideline that's available, especially in relation to the rehabilitation aspect of stroke. And hence we started to look at what's the missing gap, and also the information related to, is there a guideline, and if it's there, what's the quality of those guidelines. We were very fortunate. Last year we published this. Etienne is also a part of the team at the Global Consortium for Stroke Care. And what we did, very rigorous systematic review, looking at the clinical guidelines that's available, and then what are the unique features and the quality of these guidelines. We identified about 12 studies from low and middle income countries, which talked about clinical practice guidelines in stroke care, particularly looking at rehabilitation. And these are the efforts. If you actually look at it, you'll be very. It's easily understandable that there are about 6 contextualized guidelines for stroke care in low and middle income countries. And we have about 6 countries having 6 different guidelines. Philippines have actually reworked on the previous guidelines that was there in their own country. When I say contextualized, what I mean is these are the countries which took guidelines that are already available from high income countries and then used a framework to contextualize it for their own countries in terms of stroke care. And the information that's available on screen will clearly indicate about the countries from which the guidelines have been adopted, dominantly high income countries. and the disciplines that's covered as well. So in terms of the contextualization, you obviously see many countries do not have a framework to contextualize. Most of the clinical practice guidelines are actually contextualized from high income context. And in terms of the disciplines covered, you might also very clearly understand that it's all not coming from a multidisciplinary perspective. Obviously, it's kind of sticking to either one or two or three perspectives, say from a physiotherapy or an occupational therapy or a speech language therapies perspective. Now, if you look at countries which have actually developed guidelines on its own, it is not contextualized it from any high-income countries. They've developed it on its own. We have about 4 countries, including India and neighboring countries like Pakistan, China, and Sri Lanka, which have also developed clinical practice guidelines for stroke care, and they've covered multidisciplinary uh, professional disciplines involved in providing stroke care as a part of that new clinical practice guidelines. But again, it's a very small multidisciplinary group rather than a diverse, comprehensive group that is required for ensuring stroke care throughout the continuum in the community as well. We went ahead and then understood what is the quality of these guidelines through 2 key tools, Agree2 and Agree-Rex, and this is what we found out. So I think this is the most important learning from that specific exercise through GCSR's work, where we could obviously see in terms of the information these guidelines had, you had a very clear, good level of information from all 4 countries which developed it afresh and anew, related to the scope and purpose of the guidelines. So there was a very clear description and detail related to why these guidelines and how it was developed. And similarly, if you look at the clarity of presentation, it was fantastic. All 4 countries had a detailed presentation of what it means to have a clinical practice guidelines for stroke care in low and middle income countries, or specifically in their countries. What's not so clear in those guidelines were those 3 important aspects in relation to quality, which is rigor of the development. So how did they systematically develop these guidelines? What was the engagement and inclusion of different kinds of perspectives into the co-production of the clinical practice guidelines in these countries? That was not very clear. Applicability was not dealt at all in most of these guidelines. If you see only 2 countries mentioned about applicability in terms of how exactly this would be applicable in the context of, say, inpatient rehabilitation for stroke or outpatient rehabilitation for stroke, and even community-based rehabilitation for stroke. And there was no information about editorial independence as well. We also looked at, this is fine, the quality is compromised in terms of the important aspect that needs to be looked at when we are looking at contextualizing or developing a new stroke clinical guidelines in terms of practice. But we also looked at those countries which had contextualized it from high income countries. What were the areas that were contextualized? So obviously, those 6 countries which had a contextualized clinical practice guidelines for stroke care had all these aspects covered in the clinical practice guidelines. So we developed this table to understand the aspects of contextualization that was covered in the guidelines. So obviously, if you look at the whole table, you could visualize that the number of yellow and pink is more compared to the number of greens. And some of the key aspects we looked at was the cost of implementing these guidelines, the strategies for implementation. Is there a pathway for implementation of these guidelines in different contexts? The dissemination strategies, cultural or regional adaptations, how it aligns with the health system's strengths and weaknesses, and also the alternative recommendations, if at all, if it's not going to work out because of just contextualization from high income countries. It was very obvious that many information was missing in terms of the actual implementation of this contextualized guidelines exclusively for stroke rehabilitation in these contexts. So what's missing, as I said before, what we understood is there is a global thought on how stroke care can be provided with help of there's no dearth for income countries in terms of stroke care. Realities were different. Whether you contextualize it for income, if you actually develop a new fresh clinical guidelines for stroke in Europe. The issue is the system place. There are too many diverse in a context like India, for example, where Professor also comes from. We do not have systems in primary care that can provide comprehensive rehabilitation located in cities or in big cities of India. In terms of the best practices, the context and culture is completely different. So we need to actually look at, say, for example, if the guideline talks about feeding, we cannot think about fork and spoon. We have to think about feeding with our fingers, sitting in the ground to have our food. Using knife and fork is not going to be something that's going to work out for improving hand functions or enabling this person to eat independently on their own. Competencies of the professionals. So even in terms of the skills and competencies, we have generalized physiotherapists, generalized occupational therapists, speech language therapists, but most of them are into pediatric specialities where they treat children with disabilities as opposed to adults or somebody with neurological complications or elderly with neurological disabilities. So the skills and competencies do not match, and all those skills that's currently built in terms of capabilities, if you see, they're all built for hospital-based rehabilitation and not for community-based rehabilitation. We miss that big continuum of care in the community in the guidelines as well as in reality itself. Experiences of people will differ, and there's too many issues in relation to role clarity as well. Who does what is something that's grossly neglected, and when it comes to clinical practice guidelines in terms of who works on activities of daily living, who works on exercises, who works on sucking, swallowing, and speech, who works on cognition, for example. That there's too much of gray areas in terms of who does what. Absolutely, from the service user's perspective, this is not something that's important to them at all. All they want is the service to enable them speak, enable them communicate, enable them do their activities of daily living. So they don't mind who is giving what, but it actually reduces the quality of evidence to practice and the amount of time and resources that's taken to achieve a goal that a professional discipline specifically can achieve in those contexts. So there's a huge range of diversities in practice and contextual or system level barriers that hinder actual integration and implementation of any new clinical practice guidelines or any adopted clinical practice guidelines for stroke care to be implemented in these settings. The needs are extensive, and if you could see this particular work that's done by myself and my colleagues a few years back, obviously the top two needs are information. So people want to know what happens to me when I get a stroke, how do I identify warning signs of stroke, and where do I go if I have to actually get some amount of immediate or post immediate treatment for stroke, especially from a rehabilitation perspective. The gaps are huge. On one side, there's dearth for information in the to consume stroke care. On the other side, there are loads of skilled experts available for providing stroke rehabilitation, but they are not working together in an integrated way without a specific pathway. So availability and affordability, as well as the needs, that there's asymmetry in all these issues, finally indicating that the accessibility to stroke rehabilitation services and the paucity of evidence towards addressing this accessibility in any clinical practice guideline setting is missing. We did the same kind of work in South African setting to understand how we can promote universal health coverage for stroke care in South Africa. And we came up with a model where we looked at the dots that are intermittently connected. They are the supporting factors to ensure universal health coverage for stroke care in South African setting. And what we found out was something that's connecting the entire system to the stroke care delivery, which is the evidence-based guidelines availability, which was found to be a supporting factor, was not there in this context, given the other barriers that are there at the bottom of this particular inner circle. So overall, what's missing is clinical practice guidelines addressing the gaps in the continuum of care. So obviously, how to treat a person with stroke in a hospital setting is well understood globally. We can definitely translate that evidence to any hospital setting in low and middle income countries context, provided we have a comprehensive team to handle it according to the guidelines. However, what's missing was um, the way to address inaccessibility to stroke care in low and middle income countries context and connect those innovations that's happening in a hospital or institutional setting to reach the people who have been experiencing burden of stroke and the needs and demands for stroke rehabilitation or stroke care services in the communities. With this, I would like to stress the importance of and the need for looking at these aspects within the clinical practice guidelines, and ensuring proper integration requires all the consortiums and specialized units, including GIN, working together to strengthen integration of rehabilitation within the health systems, particularly in low and middle income countries context. I'd like to thank again GIN for this opportunity, and all of you for this wonderful active listening and engagement. Thank you.
Thank you so much, Sharif, for this wonderful presentation. I think the package is rich and it talks a lot about what we are experiencing, and it's not just within Africa, it's generally within low medium income country. So we do actually share common context when we're talking about guidelines, when we're talking about improving care and actually increasing also accessibility to care. I think your summary message there is quite clear and is quite rich in the sense that, yes, we can manage people in the hospital to some extent, but we need to think of beyond the hospital, what happens to them. Thank you once more. At this moment, I would like to listen to some of our experts who have been involved in guideline development, who have been involved in guideline implementation and done a lot about guidelines within low medium income countries. And we'll give the floor to Professor Lumna. Please briefly introduce yourself and share your perspective on guideline development and use within your own discipline. Thank you.
Thank you very much for inviting me to be part of this. In spite of how I look, I am the new kid on the block here, because it appears that you all have worked on this longer than I have. My experience, I'm an obstetrician and gynecologist by profession. I worked for 40 years in the government sector. And now have my own practice, but I have also since 1995 worked very closely with the World Health Organization. I have developed or been part of some of the guidelines they have developed, and that has got me sort of involved in the public health aspect of my profession or specialty. I was also the president of the Society of Obstetricians and Gynecologists of Pakistan from 2010 to 2013. So during that time, there was a lot of hue and cry about having guidelines in obstetrics and gynecology. I noticed when we began to work on them that a lot of us, those who were developing guidelines and those who were going to use them, didn't even know what a guideline was. So, we had to begin from scratch, that a guideline is not some cookbook or formula that will fit everyone. Even within the same country, South Asia is a very diverse country, a very diverse region. I am now the chairperson of the guideline committee. And so that same, at that point, so many years ago in Pakistan, we tried to adapt the RCOG guidelines. And of course, a lot of what was shown by Dr. Suresh, that is exactly what we found, that there was a lot that was not acceptable in the country, that was not doable. The RCOG guidelines were not meant for low middle income countries. But we did make a lot of guidelines that didn't deter us. But now in South Asia, we in our committee, we decided that making a de novo guideline is extremely resource intensive, both in human resource and financially. And the key to a good guideline, or one that is even worth the paper it is written on, is a good that it's based on evidence. And getting good, robust evidence is difficult in countries where even collecting data is a huge challenge. So starting de novo was not an option for us. Adopting again was not an option, because we can't just take something that was made for another environment and take it on in our own countries. And so we decided to adapt. And we sat and we decided that obviously it had to be a topic that was very important to our region. And we decided on PPH. And then we sat and thought about just what guidelines to adapt. So we actually looked at the 6 or 7 guidelines that WHO has made from almost 1912 to 2023, from this thing. So we looked at all those guidelines, close to about 46 recommendations we looked at, and to see just which ones would be acceptable and doable in our context. Now, in order to do that, to see that sort of acceptability and consensus, we use the RAND methodology. That once we had the guideline in place, at least in Pakistan now, I've tested that we use the RAND method for a consensus, to get expert consensus, because that's one thing we do have in low middle income countries. When you look at the quality of a data, or you look at the pyramid, and the best are the RCTs on top, and then you have the expert opinion making the huge base of the pyramid. And that we have a lot of. Everybody is an expert on almost every field. And so we had to getting a consensus on that was also important. So briefly, we went through that in Pakistan, on a scale of 1 to 9. We got experts to decide which number was that particular recommendation, so that we could, add new recommendations or chuck the ones that were there if they were not applicable to our region. Because it's not just having a recommendation, but these recommendations have then to be used, because they're not mandatory. A recommendation is basically, these are guidelines, they're not mandatory. So there has to be enough substance for individual hospitals or countries to make their protocols based on these guidelines. And WHO, I find that for low middle income countries, because there has been, the evidence is robust, and a lot of it is from low middle income countries. So it's applicable in many ways. Like, to give you a small example, our guidelines, the one we were adapting from WHO, the PCPNC guideline, was full of HIV AIDS, because they have to look at it globally. And at grassroots, that was what was important. In Pakistan, it is not a huge problem. Ours was hepatitis B and C. So we very naturally, sort of minimized the HIV AIDS recommendations and put in our own. I mean, basically, I think low middle income countries should obviously think big, which is that we must make our own guidelines de novo. But while we are waiting to get the resources, I think we need to start now. And adapting, I found, is a very, very useful process. But we must also think and acknowledge that once we've made the guideline, we also need to have um, something in place, some process in place to see the effect of those guidelines, whether they have been, are they being used, and has it made a positive impact in whatever we are trying to mitigate. So that's one aspect that we totally leave. We come in, sometimes even spend money and time, make these guidelines, but what is happening? It's happening even to the WHO guidelines. They're really good guidelines, but they're not effectively disseminated or implemented. And I think that is an area that I feel that we should really work on.
Right.
So I think I'll just stop with that. If there are any questions or, this thing, I can just answer anybody. Thank
Well,
you.
thank you so much. Thank you so much, Solumna, for sharing your perspective. Please, can you just put in full the meaning of PPH and RUG? I mean, sometimes when you are talking
Oh, sorry,
and it's
sir.
really not
Yeah,
in your context, then
okay, I've been an obstetrician for 50 odd years. So PPH is postpartum hemorrhage,
yeah.
okay,
And,
which
and
is the biggest killer of women in childbirth. So obviously, it's very, very important to obstetricians. And
RUG, please.
RCUG is the Royal College of Obstetricians and Gynecologists in London,
Okay.
where I have qualified from. So we thought that, oh, that is the thing, but we found out it wasn't at all. It was not for us.
All right. Thank you so much. Thank you so much. I think you've perfectly aligned with one of the summary message from Suresh presentation about thinking about implementation because recommendation in isolation make no sense. You've rightly put it. It doesn't even worth the paper that it is written on it, if at all it's not used. Thank you. And at this moment, we would like to listen to Professor Joseph Matthew for to share his perspective and experience within guideline use and development. Thank you.
Thank you, Etienne. I'm not going to show any slides so that this remains an informal conversation. And I just wanted to highlight, first of all, how glad I am to be here. I can see a lot of friends across the globe who are present in this meeting. So a big hello to everyone. Good morning, good afternoon, good evening, as the case may be. Now, very quickly, I think some of the things that interfere with guideline development and implementation in the context of LMICs across the three or four continents are as follows. One is we have to have a clear distinction between a guideline and an evidence-based guideline. The two are not the same. They are often made out to be the same, but they are entirely different things. So when we're talking in the next few minutes, I'm going to be talking about evidence-based guidelines and not the usual guidelines. The second point is the developing countries face what I call the curse of the consensus. So people have this misperception that if a bunch of experts got together in a room and came to an agreement on something, whether it is copy pasted from another guideline or lifted from another guideline and tweaked to suit their settings, that would become a useful evidence-based guideline. I think it's better not to waste time and energy on that, even though they are very helpful, but they are in what is called in the trade untrustworthy. So therefore, it might be better not to try and invent those kind of guidelines at all. And the reason why I call it the curse of the consensus is that in most developing country settings, the word consensus is simply the absence of dissent. So one expert in the room who has either read up this subject more than the others or is driven by some kind of an interest does all the talking. Everyone nods their heads wisely, does not contradict what is being said. So no dissent, therefore it is consent, and the document comes out as the consensus statement. So what I'm saying here does not apply to those kind of guidelines at all, even though they may be useful documents. We all went through that in COVID, but really not the focus here. The way to make an evidence-based guideline, of course, has been well laid out in the WHO documents. But there is a 12-step process. Every group that wants to make an evidence-based guideline should follow the 12-step process. The only problem is that it can be technically heavy and challenging and demanding because it involves setting up questions beforehand, finding the evidence to address and answer those questions, doing quality appraisal of the evidence, grading the evidence, and then finally coming to an educated set of draft recommendations. Some of this technical expertise is not available in the LMICs, and so therefore that's a temptation to deviate from this process. But my focus in the last few years has been to work on getting an evidence-based guideline in the context of an LMIC setting with great economy and efficiency. So by economy, I mean, can we produce an evidence-based guideline with $0 budget? In my country, it's called rupees, but let's use dollar as the generic term for money. And I'm very pleased to say that we succeeded in this. We can develop an evidence-based guideline, and it's a published kind of a format for that. But it becomes very resource intensive in terms of human resource and also in terms of time resource. Because when you don't have money exchanging hands, then you've got to rely on the goodwill of people. You've got to piggyback on their limited expertise, train them as you go along and things like that. But the great thing is that it is possible. And why that is important is all LMICs face this challenge of severely constrained budgets, no way to produce a decent guideline in a limited time frame with the amounts of funding that developed countries can put into it. So therefore, a zero budget or a very economically useful model can be emulated in different countries. The second point I wanted to raise is about efficiency. So every country and every body within a country is trying to produce a guideline for the same things. So it's possible that, in India, I'm giving a very crude example, that the pediatricians in India want to produce a guideline, say, for 5 conditions, pneumonia, diarrhea, this and that and the other. The same thing is happening, 2 countries down the line, say in Bangladesh or Sri Lanka or China or Vietnam or someone. And the contexts will be different, but the context will be different even within a country. That's a given. So why not collaborate and work together rather than each country, each professional society within a country producing its own guidelines and then trying to call it, okay, the Indian guidelines on this, the Bangladeshi guidelines on that. They're all going to be talking of the same thing. They're the same 5 or 6 RCTs, limited body of evidence. Only the grading is going to change slightly. So we could reach a world wherein all LMIC stakeholders could come together to a common platform on a given topic, look at the questions of relevance together, frame them in the PICO format, do the evidence synthesis, break away from each other to do the grading of evidence because that is highly context dependent, come back together to put the draft recommendations, and then again separate out to make those draft recommendations into real world recommendations. We could do this so much more efficiently, so much more economically, and so much more less resource and time intensive. But that's if we all did together and work together. The last point I wanted to make is sometimes a guideline and its recommendations can be generic, but its implementation is local and contextual. So if you look at the resuscitation guidelines, there's no need for any country to develop them. The same guidelines seem to work. When do you do cardiac compression? When do you do artificial respiration if somebody collapses on the street? The same standard guideline which has been produced by a global body like, say, American Heart Association is just used everywhere. There may be minor tweaks because the American guideline will say, if you see this, dial 911. 911 may not be applicable in the context of India or Cameroon. So you'll have to dial the local number and see whether it produces the same kind of response or not. And if there is no mechanism for that, remove that part from the guideline. So I think it is much more efficient to also work with existing evidence-based guidelines, and rather than adapting or adopting them, ask ourselves this one central question. What is there in this guideline which prevents me from using it as it is? And if we can then identify the answers to those points, then we can work around those. And there will be sections in any guideline which are generic and implementable across all settings. Some which will need to be highly contextualized because either there is challenges in terms of availability, affordability, or accessibility of the interventions that are being talked about. So if I had to summarize this whole rant for about 5 minutes, what I want to say is Guideline is not the same as evidence-based guideline. Focus only on the latter, ignore and sideline the former. Second, two words with C that are critically important. One is consensus is a curse. The second C word is contextualization is of prime importance. And three E words that I wanted to leave everyone with. One is economy. We need to produce guidelines in the developing countries at the lowest cost possible. The second is efficiency in terms of human resource, time resource, material resource. And the third is excellence. Because if these guidelines are not being implemented, and no one is going to change anything on the ground, but we just have dead documents sitting in some journal or in somebody's CV, then again, we are not really going to change the healthcare system and the way that we practice and deliver healthcare. So just two C words, three E words. Thank you very much for your patience and understanding.
Thank you so much. I think I must appreciate your wisdom in the practical wisdom and your availability for sharing with us. Summarily, I think we go by this statement that all human beings, black or white, Asia or Africa, are more similar than they are different. And those differences, we can manage it with ease if we actually acknowledge each other as humans and we work together in that sense. We'll actually save a lot of money and live in harmony. Thank you so much. Thank you. At this juncture, I would like to give the floor to Professor Radhika to share her perspective with us. Thank you.
Thank you very much, Etienne. So, good morning, afternoon, and evening to everybody from various parts of this world. And it's indeed a great pleasure to be here. I think for me, it is first time. Etienne has had a similar meeting last month. I think it's a great idea for us to get together and a forum for us to exchange ideas and maybe move forward. And I would really say the last three speakers, it's been a very stimulating session. I think problems and solutions both well presented. So I have my own experiences too. So I work as an obstetrician and gynecologist in India. And my focus has also been on having guidelines in my country and in the Indian continent. So I just wish to make a very brief show of 3 slides of what our experience has been like, you know. So are my slides visible? Is this visible, please?
Yes, please. We can see record identified from database. Yep.
Okay. So this was a presentation that we had done in the year 2019. So we had gone through what is available in India in terms of guidelines. So like Dr. Joseph very clearly identified guidelines versus evidence-based guidelines. So these were all guidelines, quote unquote. So we got so many documents and duplicates were removed, and finally we ended up, you know, we wanted to do a quality appraisal of the guidelines that were available in India in the field of obstetrics and gynecologists. So we ended up having 8 guidelines, and this is the characteristics of the guidelines. So as you would find here, the agency which had stimulated the people to work on these guidelines was the Association of Obstetricians and Gynecologists of Delhi, and also the Federation of Obstetricians and Gynecologists. So they were variously labeled as good clinical guidelines, good clinical, general clinical practice recommendations, and none of them were, de novo. Actually, they were all contextual, and they had been, there was no great differentiation. People could not really, identify the kind of document that they were producing. So that is where the consensus being a curse is what I would talk about. So one person talks about it, everybody agrees, and that's how it went on. And this slide also shows something similar to what Suresh had presented. So this was the agreed to scores of the guidelines that we had studied, and we found that the scope and purpose of these guidelines was quite good. However, the rigor of development, as you can see in purple, and the applicability and the editorial independence was hardly there in any of these clinical practice guidelines, so-called. So this is what we wanted to bring forth to our societies, and also to be able to bring forth and urge the clinicians to get down to the process of clinical practice guidelines development. So the final take was none of the guidelines were recommended for use. None of these were peer reviewed. There was no plan for updating or an audit plan. There was no declaration of conflict of interest or or the funding body, and so there was lack of transparency. So this is very briefly what we found, and the changes. There is, it's not greatly different that you would find here today in 2025. So we have the National Health Mission. So this says NHM guidelines. So you can see so many guidelines. Other than that, this the site also has technical specifications for equipments, for ENT department, and suddenly then they come to guidance of document for implementing lab services, then guidelines for telemedicine. So it is all very confusing here. So going on to the Federation of Obstetricians and Gynecologists, so you can find in 2024 lot of work has been done, lot of documents have been brought about. These are again in the title of good clinical practice recommendations. So they are more like, I would say, copying and pasting. Very sorry to say that. So the rigor of guideline development hasn't actually taken place. So that is the way it is, and so I think we have a long way to go. So I think the solutions were very well presented by Dr. Joseph. In fact, I was an observer in one of the guidelines that the pediatricians were developing, led by Dr. Joseph. So what was impressive to me was the dedication with which the pediatricians were working on it. Now, I would say there are two things that are problematic for us to start with. It's a great idea for us to get together and start working on a document. For instance, Dr. Lubna, she formulated a group for the South Asian Federation of Obstetricians and Gynecologists to develop guidelines. So we try to form a core group. It's so difficult to have people working on this subject, number one. And the reason that I can identify are basically two. Number one, there is great diffidence because there is a feeling that it is very difficult. It is time consuming. Obstetrics and gynecology is a very, very demanding branch. How many of us really wish to undertake this process of developing an evidence-based guideline? That's number one. Number two, the processes are not clear. Capacity building today is extremely important for people to understand the processes that go into developing a clinical practice guideline. So that is where I talk about adaptation and the adopting a guideline. So I think this is something that I and Dr. Joseph could start a debate on. So while we are in the process of developing a guideline, is this a good point? Is this a good thought? Or is it an option for us to consider adapting a guideline? So yes, it's a good idea. So RCOG guidelines, like Dr. Lubna said, is something that we fall back on. So we do that in India too. So it's not only the Royal College, we also talk about the American College and also, of course, the WHO. The problem is availability of those resources and also the feasibility of doing some of the steps that those guidelines talk about. The problem is WHO doesn't address all the aspects of gynecology and obstetrics that we would possibly want. The Indian Council of Medical Research in India has started having some sort of movement in that direction, but it is yet to be successfully doing anything. So it will, for me, as to see in the future, it will take at least 2 to 3 years for us to reach anywhere. So do we think it's a good point in time to start capacity building? So while we could work on, bringing out those guidelines, I think it is extremely important for us to start training our people. And in the meantime, also have, we have the guidelines adaptation group with the Guidelines International Network. In fact, I remember having written to Dr. Yasser about twice to be having these, these sessions probably once a month, to sensitize people on the process of adaptation. So those are a few areas that we could think of. And then, of course, implementation and auditing those processes. After all this effort, is it really getting used in the grassroots? So I think we need to see that and address those issues too. So I think now is a good time. We should set the ball rolling and have a consensus. Uh, Even though, probably here it may not be actually a curse. So this could be a point for us to start moving forward. So thank you so much for your hearing, for your patient hearing.
Good. Thank you so much, Dr. Radhika, for this presentation. I think that has been eye-opening, and definitely we'll have more congent discussion and map a good way out. I think that is the sole purpose of a forum like this, and to have people discuss and share their views. Before I go ahead with questions and answers, I just would like to appreciate all the panelists for sharing their ideas and sharing their wealth of experience in guideline development and use. And we are inviting in our upcoming webinar series, Monday webinars, anybody interested or have built any form of experience that would like to share, can please contact me or any of our team members to actually arrange this and make it happen. One of the challenges is actually the way we disseminate some of the work we do, even as you mentioned, even from very well-established organizations like WHO. Active dissemination is something that we cannot undermine. I can recall discussing this in one forum, and one professor says, if it gets budgeted, then it gets done. And we still have, for instance, even grants that apply. They look about the product, but producing the product, and then we don't think about how it will be saved or distributed to the end users. I think that is one thing that we should consider, and we should look at channels within our context that we can actually do this. Okay, moving away from that, at this juncture, we would like to welcome any questions, and if you do have a question, please just raise your hand, and we'll definitely coordinate that, and then you can ask your questions or provide answers to any questions. Before I give the floor to anyone with any question, I will just like to kind of highlight some of the my perspective, or to challenge the presenters on some of the things that we've discussed here, because we've talked about, we are discussing this from a more practical experience. So this goes first to Suresh, even though it cuts across all the presenters. One is that you've clearly identified guidelines, especially a stroke guideline, to be heavily lean oriented towards clinical practice and not involving, for instance, community rehabilitation, in which case people, when they have their stroke, they don't live in the hospital, they live in the community. But one of the real world, one of the reality is sometimes getting these guidelines and experts, it is actually a broad kind of circle or different stakeholder, which makes it a little bit complex. And we must be able to actually see how we can get, for instance, social workers or people who, the Ministry of Social Welfare, and then now in the clinical practice, we must talk about people with interest in clinical practice or the Ministry of Health itself. Have you any idea about moving forward, how we can liaise this or bring about this, reduce this fragmentation and bring this synergy in terms of either a particular condition, in this case, you presented on stroke, or to any of the speakers in any, using any condition or context I think this is something we should discuss, because if we really have to address real world problem, these are some of the things we should be able to try to really highlight in our context. Thank you.
Thanks, Irina. I'll go last because all of us who presented are from India, so probably I'll get to the last bit of the heaps of advice you'll have from the other speakers. So I request Dr. Joseph or Dr. Radhika to start off, please.
Yeah, I don't have anything really new to add. Thank you.
Same here. I think guidelines are required for every level of healthcare, and it's extremely important to consider that. In fact, now there are there's something called the standard treatment workflow being developed by the Indian Council of Medical Research. So it's like a single page document. So they address the possibilities of addressing the treatment aspects or the management aspects at various levels of healthcare. So those have been there for some time. Again, the problem was that the dissemination wasn't good enough, but now it is getting disseminated, and we are now planning to see how it is going to be taken up, what are the implementation aspects of it, and what difference it makes in terms of the outcomes. So it's still early stages, but yes, we are aware that it's important that the last mile, has to be reached. I agree.
Okay.
Sorry, Dr. Lubna, yeah, I missed you as well to say, please.
Yes,
Okay. I just taking it forward, but Radhika has all said it, but I thought we should add another C to all of this is the continuum of care. Because as Suresh said, that there is a lot happening in hospitals, at least in most of our countries, where the larger teaching hospitals are almost at par with many of the high hospitals in high-income countries, and so they have access. All their teachers are trained abroad. They have access to all the global protocols. The issue is, especially in obstetrics, the issue is, the other levels of care, where, a woman doesn't get pregnant in the hospital. So her journey begins in a village somewhere where she's looked after by not necessarily a trained skilled birth attendant. And so why WHO's guidelines are so attractive in some aspects of obstetrics, I agree with Radhika, that not in all, is that they address all levels of care, to have that continuum. Otherwise, there is, many of these women slip through, and that is why, the end result is a high maternal mortality and poor healthcare for women. So I think when we look at guidelines, this thing of continuum of care must be addressed.
well,
Otherwise, final impact will not be there.
Yeah, thank you so much. Yeah, I think continuum of care is actually very important, and the issue is how do we then engage people in the different phases? Because now, when you allow, for instance, the community rehabilitation, maybe in the hands of quote and unquote social welfare, they might not be there to take it anywhere further. So that is left completely out of the guideline, which then you just break it. And so there is need for us to really look at how we can engage or different stakeholder in guideline development and dissemination. Any question before I ask my next question?
I'll finish off my bit as well.
Okay.
If that's okay.
Thank you.
I said I'll go last. I didn't go at all. So I think the question is very important to think about, basically from a capability building perspective, meaning who looks at these guidelines, who wants these guidelines to be developed, and if you see in terms of stroke care, the guidelines are more welcomed by the clinicians themselves. By clinicians, I mean everybody who's involved in stroke care, including allied health professionals. Now, when it comes to community care, uh, these professionals who are very good to look at what should I do in a hospital setting do not actually know what should they do in the community setting. There comes Dr. Lubna's question of how do we look at evidence in the community, because we have not worked on it at all. We are looking at acute setting. We are looking at an ideal environment where something could be provided for somebody with stroke. Whereas the real environment where the stroke survivor and the family is experiencing the real world and the real systems in place to support them, we don't have guidelines to work within that system. So obviously you can say you need to actually get TENS for your pain, for example, or you need to actually get into a treadmill or get into a parallel bar to learn mobility. But is that possible in a community setting where I have a rented property, where I cannot actually alter my toilet to get inside using a wheelchair? So I think the connection lies in building the capabilities of those people who are interested in generating or developing guidelines to focus more on connecting the realities of those people who are experiencing disabilities as well, not just from a stroke perspective, but from any life-limiting chronic disease perspective as well. And one way of looking at it is actually to work with the systems. By systems, I mean work with government systems, which have, as Dr. Radhika was mentioning, we have National Health Mission, we have National Stroke Program in India from 2006, but we do not have any report on what's happening in the community under the specific program. And similarly, we have about 24 national programs in the country. And if you look at practice guidelines for connecting the community level work to whatever is happening within the national programs, we don't have people inclusively looking at developing guidelines or implementing guidelines from those perspectives. So I think both at the level of decision makers as well as at the decision of at the level of clinicians, we need to look at capacity building or capability building programs, enriching them with experience of looking at connecting communities in the aspect of developing any clinical practice guideline or contextualizing it.
Thank you so much. Okay. Any question from the audience, please? Okay. Please, I think Dr. Joseph actually highlighted the difference between evidence-based and non-evidence-based guideline. Yeah, when you read the literature, sometimes it says even when the evidence is not there, making recommendation is more helpful. So we can make recommendations to inform clinical practice, to inform public health practice, even when we have limited recommendation, rather than leaving it completely without it. And moreover, majority of areas in health in the low medium income countries don't have robust research to actually inform some of these recommendations. Nor do we have quality improvement capacity that evaluates some of these practice to say we are doing this and this has improved and inform some of these areas that we do make recommendations or are trying to improve. In this case, where we lack the evidence and we lack the capacity to actually provide these recommendations based on the evidence, even when we are adapting, what is your take on that? Should we go ahead to do that, or should we, excuse me, sorry. So yeah, should we go ahead in terms of producing guideline developing the guidelines with poor, robust studies, evidence within our context? Or I know also that in some contexts, decisions are favored not purely by a clinical practice guideline, because even some of the highly well-developed guidelines, evidence-informed, not used, nor are they disseminated properly. So first thing first is, we don't have guideline in some practices. Say in my village, there is a health center operating. They don't have a guideline. Should we develop one which is more suitable for the context, even though the evidence is not strong? That's my first question to the panel, please.
May I go first?
Yes, please.
Yeah, so I think this is something that we've been facing in India very often. So we recently finished a systematic review to understand the rising cesarean rates, and if there are ways to get it down, and what are the recommendations that we can develop. So what the kind of studies, I totally agree with you, Etienne. We do not have robust studies to base our the guidelines on. That is a basic problem. But yes, they are also important. They are important pieces of information that are there. So the quality of recommendation and the level of evidence, the strength of recommendation may be it could be affected by the quality of evidence that is there. But we need to start. It needs to be present, and it needs to be presented to the audience and the users to say that these are the gaps in research. So not only is it is the process of developing a guideline, it's also extremely important for us to have good clinical research. So and of course the areas of research. So these are three things that would get highlighted from these guidelines. And number two, I think there is still a misconception. People take the guidelines as a legal document, and there is a lot of hesitancy amongst the clinicians to develop a guideline because they feel that the onus comes on them, and then it's a legal document, and to what extent the people, the authors, can be affected because of incomplete or improper information. So that's one aspect which also needs to be covered during the sensitization and capacity building, the programs that we have. So I think it is important to start somewhere, and it is better to start with what we have.
Thank you. Thank you so much.
I would basically add a couple more points to say there should be active advocacy of the work that's done at the policy making or decision making level. So what we do is we develop these beautiful guidelines which are evidence based, which are very rigorous, and then we hand it out to a high impact international journal and then stop there. So I think one thing that we got to take forward is to also advocate for the work. So just like how I did in this particular community, in terms of what we did for stroke care and the way we are looking at working together, like Dr. Joseph was saying. So the consortium is actually built to do that, not just for the guidelines, but also to take the idea forward and then look at all the aspects that we have been talking about, right from somebody who's experiencing a stroke till the time that he gets back to his family and home, and being a productive member of the society to the end. So I think advocacy is very important because investment happens through the government. And as you rightly said, if there is funding, then there is kind of a responsibility to look after the work that's going to be happening through there. So an advocacy can obviously help us connect with right people and then make sure that we get some projects to continue the work and implement whatever we dream for. Thank you.
Thank you so much.
If I can just add a few sentences.
Yeah.
I think what Radhika said is just so true that we can't, just because it is difficult, there are a lot of challenges, doesn't mean that we should not be doing anything. There is low-hanging fruit. Perhaps there's some specialties or some areas of some specialties that we cannot touch yet because we don't have the evidence. But there's plenty of evidence and low-lying fruit that we can definitely, that there is robust evidence, there's global evidence that we can definitely begin to work on. And in order, as I said over and over again, that implementation is the key to everything in order to see the impact. Collaboration and networking, as we are doing just now, within our own countries, within our regions, and even beyond, I think is the key, because we do have expertise in our midst. But whether those experts are being used, we tend to look, the South tends to look at the North as if they have all the answers. They do have many of the answers because of their resources and the lot of hard work that they're doing. But what we can give with our experience is that much better in our own context. So I think collaboration we must continue, whether it's within, from policy to the clinicians, to the UN agencies, to the donors. Everybody has their own strength and something to bring to the table. And we must, bring everybody into the fold. And that is the way forward, I feel.
Well, thank you so much. Dr. Joseph, do you want to give any reaction, or shall I?
No, not a reaction, but I can see also Dr. Yasser's hand is up.
Yeah, that's what.
But I just wanted to say that I think we should not allow the need to get something done interfere with the goal of getting it done properly. My personal take is it's better not to embark on a thing which is not going to be robust and trustworthy than say that, okay, because we can't do a trustworthy thing, so let's get away with doing something, and something is better than nothing. But that's my personal opinion. Thank you.
Thank you. Thank you for sharing. Okay. Yeah. Lumna, your hand was up. Yes, is it? Yes, please. Have the floor.
Thank you so much. I enjoyed the rich discussion. I mean, you have already covered all of the issues and barriers, but I think maybe I bring an input from North Africa, from Egypt. So most of the barriers that you have mentioned, I've experienced personally in a lot of guideline projects, whether institutional or national. So I would like to echo Dr. Olna and Dr. Joseph and everyone's, suggestions about the importance of investing in local cadres. Capacity building and training of local staff who are full-time dedicated for this. I think most of us, sort of by background, we are clinicians or healthcare providers with a special interest in EBM and guidelines. Not in all of our countries we have full-time, for example, guideline methodologists with this job title with a fixed salary or something. So having this specific job description with institutions that young generations can build a career on without having it as a part-time job or part-time activity. This is one thing. So capacity building of local cadre in our regions or countries. And also, regarding the lack of funding, there's a lot of available resources, especially by the World Health Organization, whether training resources or tools that are freely available and do not require any subscription or any payment. This is another, good solution like you have suggested. And thirdly, and I think this is one of the very nice fruits that we can make use of, collaboration between us, between our countries, between our regions, because sometimes some colleagues have more experience than others, or in some certain specific, maybe it's an organizational or institutional guideline project, or even a national guideline project. So it will be a very rich experience. If we can all contribute or participate in one, maybe, I don't know, regional guideline project, or even if it's a local guideline. But the shared experience from different contexts actually build our own experience as well, and whether in guideline adaptation or implementation, or how to address implementation barriers and so forth. And just the last point about the problem about the post-production, the implementation and audit and so forth. Apart from considering guidelines as legal documents, they're not legal documents. There's no consensus on that till now. But most of national insurance organizations are trying to use guidelines or push the production of guidelines to be used as the insurance paid payment. And also accreditation bodies, frankly, state in most of them that medical teams have to use guidelines. And even recently, the newer accreditation standards are starting to show evidence-based guidelines and using the agree to and using grade. And these terms are starting to show, and even in accreditation standards, they now no longer ask for guidelines only. No, they start asking for evidence-based guidelines and evidence-based pathways and so forth. Thank you very much.
Thank you so much for sharing your experience with us. Thank you indeed. Okay, any question? Lumna, I saw your hand up. Was that?
Yeah, I just wanted to make sure to have some clarity here that I did not in any way suggest that we should, just for the sake of making a guideline, make poor quality guidelines. I think that would be a sin. What I meant was that let's not reinvent the wheel. If contextually favorable and acceptable other guidelines exist, then we can collaborate or adapt and then be part of the implementation in our own areas or regions. Instead of just saying that since we don't have the resources or the capacity to make a guideline de novo, we should not be doing anything. That was my sort of implication of what I said. Not that, that is what I'm strictly against, that there's no point in having a guideline. It can be very, very harmful if it is, not robust and evidence-based. So that was not my intention at all. I just merely said that, we should collaborate, and perhaps there are guidelines that we can use no matter what our state of resources.
All right, thank you very much. I think that is quite clearly taken by everyone. Okay, if there's no question at this juncture, I would like to formally end the meeting now. But if you have some few minutes to hang around for any networking session or discuss anything further with respect to either today's discussion or future discussion, then you can do that after the recording is stopped. I want to say thank you to all our esteemed panelists. Thank you for your marvelous contribution. It's really been an honor to actually host you by Gene Africa and Gene Low Medium Income Country. And we are looking forward to having this joint webinar series with all of you again in the near future. Thank you.
Thank you all.